Yes, my name is Kabigo Ibra, Department of Surgery. We have a second case. This is a 36-year-old male, BF, from Namutumba. He's a Musoga and he's a married man. He's a Catholic and is a older patient. Newly diagnosed hypertensive patient on treatment. He presented with abdominal pain for 4 months, palpitations for 3 months, profuse sweating, and on and off headaches for still 3 months. In the history of presenting complaint, BF presented with pain in the right flank for 4 months that was dull and unradiating, relieved by analgesics, for example, aspirin. He had no history of constipation, and the rest of the bowel habits were normal. Menstruation habits were normal. The urine was of normal color, and also reported no jaundice. There was no jaundice. He reported a 3-month history of palpitations that would persist even at rest, but no other cardiovascular symptoms. He had no swelling of lower limbs, no difficulty in breathing. He reported of headache that was on and off, but no other neurological signs. He gets profuse sweating, but no fever. In the review of other systems, respiratory system, he really had no complaint. He had no cough, no chest pain. In the ENT, he had no major complaint, musculoskeletal. Apart from the abdominal pain that he had reported, he had no other complaint. Skin, he had no changes and no lesions. In the past surgical and medical history, this was his 3rd admission. The first 2 occurring in Iganga, all about the same illness. The first 2, with a similar presentation, he was screened for infection and serology, all of which they found negative. Only that he was found to have a high BP and was put on unknown antihypertensive treatment. In the past surgical history, he had no history of trauma, no history of blood transfusion, no history of operations. Family social, he's the last born of 4. He reported no known familial illness. He's a married man with 7 children, and as reported before, he's a welder. Occasionally takes alcohol, though not compelled to do so, and is a non-smoker. In summary, BF is a 36-year-old male who is newly diagnosed hypertensive patient on treatment with a 4-month history of right-sided abdominal pain, specifically no constipation, and no other bowel or menstruation symptoms. It reports of a headache and palpitations, sweats profusely but no fever, and no familial illness was reported in this patient. Thank you. My colleague will pass through the examination findings as we're going to transfer.
In the examination, was a young man who was sick-looking, moderately wasted. His skin was of normal thickness without ecchymosis or myxedema. He was febrile to touch on the day during that particular examination, and he was sweating profusely. His eyes were normal. He did not have any anterior neck masses, and he had no cervical lymphadenopathies. He had normal hair texture and distribution, and he had no frontal balding. Cardiovascular findings, he had a gallop rhythm with a tachycardia. His heart rate was 120 beats per minute. He had high blood pressures, and he exhibited postural drops. Supine BP on that occasion, on that day, it was 180/110. Sitting BP was 170/100, and the standing blood pressure was 150/85 millimeters of mercury. There were no murmurs were appreciated. Respiratory system, the chest was symmetrical in size and movement. His respiratory rate was 20 breaths per minute. He had normal vesicular breath sounds bilaterally. And his abdominal findings, on inspection, the abdomen was moving symmetrically with respiration and was of normal fullness. The skin had no striae or surgical scars, and it didn't have any visible engorgement of veins over the anterior abdominal wall. And on palpation, He had rigidity over the right lumbar region. He had right renal angle tenderness. The spleen and liver were not enlarged, and neither did he have ascites. On auscultation, he had normal bowel sounds, but no bruise were had on auscultation, and rectal examination findings were normal. Our impression was secondary hypertension, possibly due to a pheochromocytoma. This was in view of the classical triad that he presented with, which is diaphoresis, headache, and palpitations. He also had postural drops in blood pressures, which are common in pheochromocytoma, and there was that presence of right angle tenderness, which pointed to a renal or suprarenal mass. And our differentials included thyrotoxicosis, possibly renal disease, nephritis or renal vascular occlusion, multiple endocrine neoplasias, 2A or 2B, other endocrine diseases such as Cushing's or Crohn's. My colleague will go on with the investigations.
So with the increasing suspicion of pheochromocytoma, a series of investigations were done to exactly come up with the actual diagnosis. So we had 3 categories of investigations which were done. We did a baseline, which included the complete blood count, liver and renal functional tests, plus serum electrolytes. And then also the second category, we looked at the biochemical analysis of the catecholamine production within urine, and we were only able to do the VMA. Then we also went ahead to do localizing investigations, which included the abdominal ultrasound scan and abdominal CT scan. In an ideal setting, I would have wanted to do a 24-hour urine collection, whereby we could monitor catecholamines, metanephrines, and VMA. And the positive results will depend on the elevations of these findings. If you have a 2- to 3-fold elevation, it would highly be suspicious, or would be in position to highly think of a pheochromocytoma due to that increment. However, we may also have conditions that can give us false positive results, as we shall see. If you are to do a 24-hour urine catecholamine, usually this one has a sensitivity of about 83 and a specificity of 88%. And the total metanephrines usually have a sensitivity of 76% and a specificity of 94%. So if you are to get a combination of the total urine catecholamine and also a total urine metanephrines, you'll have a very high sensitivity of 90% and a specificity of 98%. But as we all know, in our settings, we have limitations because most of these are not readily available to our patients. So sensitivity will always be increased if 24-hour urine collection began at the onset of the paroxysm. So that is. So now we could also, in an ideal setting, we could also go ahead to look at the plasma catecholamines. The challenge with this is that these ones have some patient preparation that you have to do, whereby you have to draw when the patient has fasted in supine and with an indwelling catheter which has been in place for greater than 30 minutes. Otherwise, to give you falsely elevated results. So if you have plasma total catecholamines greater than 11.8, that is highly suspicious of a pheochromocytoma. We can also go ahead to do plasma metanephrines, and these are quite okay because they don't require a lot of patient preparation, in that you don't need, they're not dependent on the posture of the patient, and they can be drawn normally, even with the cannula that has just been inserted in. And we shall realize that they also have a good sensitivity, which is 99% and a specificity of 89. So, but however, we should be careful. If a patient has been taking acetaminophen, we may be able to get false positive or false elevations of the metanephrines. So this is just a summary of the biochemical tests that could have been done, and some of which we did. So, and as you may see, we have the different biochemical tests and their sensitivity and you may agree with me that plasma metanephrines has a very high sensitivity, although and also a relatively fair specificity for pheochromocytoma. These tests used to be done, but because of the risks that they confer to a patient, they seem to be phasing out. The clonidine suppression test, this which is used to be done, but it confers a risk of hypotensive shock, so it is also being phased out. Then we have the glucagon stimulation test, which also confers a risk of hypertensive crisis, so that's also the reason why it is also being phased out. So in our patient, we didn't do any of those. We concentrated on the metanephrine and we did the VMA. We also went ahead to do localizing imaging, and of interest was the CT abdomen. The localizing investigations were done, and a colleague of ours from the radiology department is going to come up to give us the details of what was found on the CT scan and also an abdominal ultrasound scan. We were not able to do the MRI because the CT scan and the abdominal ultrasound scan was sensitive enough to help us make the diagnosis and also the location of the tumor.